Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
We're very fortunate today to have Merrick Ross as our guest, joining us from MD Anderson, actually, as you can see, on his scrubs. So welcome, Merrick. Thank you. Yeah. Thank you for joining us. And maybe just to start off with a few background questions: where you grew up, how you ended up where you are today, why you became a surgical oncologist, and then after that we can get into questions about surgery for melanoma. So over to you.
Yeah, well, that may take 30 minutes, and so I grew up in one of the northern suburbs of Chicago, and you may have heard of this little village. It's called Skokie, Illinois. So Skokie has two claims to fame. The first one is that when I was growing up, the population of the village was 70,000, which is actually pretty big, right? And it was proclaimed as the largest village in the world. Oh. However you define village, right? So the other claim to fame was that you may know that there was a march back there with the Nazis. Remember? It had national news because at that time, it was the largest number of survivors of the Holocaust lived in Skokie.
Oh, wow.
Wow.
Yeah. So there was this, march, whatever. So that's enough about Skokie. Anyways, so I went to college at University of Illinois, which is in Champaign-Urbana. And I went to medical school at the University of Illinois in Chicago. And then I did my surgery residency at University of Illinois, Chicago as well, which included spending about 65% of our time at Cook County Hospital, which I'm sure you've all heard of, right? Yeah. So kind of a war zone, in terms of trauma and stuff, and really bad pathology. So why surgery? Okay. Well, my medical school graduating class was surprised that I went into surgery, right? Mm-hmm. But I realized that during different rotations, I felt that you could use a lot of stuff that you learned in internal medicine to be like a better surgeon, right? Mm-hmm. So I kind of viewed myself as like a thinking surgeon, because at the time, people didn't really, people viewed surgeons as more technical wizards rather than, thinking about the disease. And as it turns out, surgical disease is really interesting. And then I decided I was going to do an oncology fellowship, because we actually had what was called a surgical oncology kind of rotation during my residency, which was very unusual. There was a guy named Tapas Dasgupta who was interested in melanoma, as a matter of fact, and was actually giving DTIC for melanoma. He was also interested in sarcoma. So he started this kind of oncology rotation and went around the state recruiting small communities to participate in clinical trials. It was pretty remarkable.
Cool.
He may still be alive, I'm not sure, but he was a great guy. So that was kind of my first exposure to what was called surgical oncology. And no one even knew what that was back then. So when I did my fellowship in 1987, a long time ago, and that was Charles Balch's fellowship, we had five people in my first fellowship class, and then it was a two-year fellowship, and then I stayed on staff, and I've been there for 37 years, believe it or not.
So it's Chicago to Houston, and that's it? I mean, Illinois to Houston.
Yeah, and that's it.
Wow.
Yeah.
Wow.
Yeah, not all that interesting, right? Not all that interesting.
No, that's incredibly interesting. It's always fascinating to hear people, where they grew up and then what that draws them. But what's interesting to me is the adjustment in climate you had to do. You had to really go from winters to summers.
believe it or not, the summertime in Chicago could be pretty bad too in
True.
terms
Yeah.
of heat and humidity. But back then, the winters were impossible.
Yeah.
Impossible. It's definitely warmed up a little bit. I'm
Yeah.
sure, the non-believers in climate change, you can't convince a Chicagoan that that's the case, right?
Yeah.
Because the winters have definitely softened up significantly. Yeah.
I was just wondering to myself why people ex-US might have heard of Cook County, what the sort of the primary kind of modality was for people. And I just thought about The Fugitive. I don't know if you watched that film.
Yeah, sure. Yeah, there were some real video clips there in the
Yeah.
movie. It was very accurate. Very accurate.
Yeah, well, including the bit where the janitor diagnoses the tension pneumothorax, changes the orders, puts the kid in a lift, right, and then saves his life.
Yeah, it was pretty chaotic there. Like when we had trauma cases that came in and we needed to bring them right up to the operating room, it was a mess.
Yeah.
Yeah.
Wow. Incredible.
Right. No, yeah, you're going to say something anyway. So
well, I mean, that takes us, as you say, you entered surgical oncology and then here you are kind of ever since. That means that you've really seen the evolution of surgery going from kind of a primary modality or this, the standalone modality for many cancers to becoming multimodality. Where have you seen surgery go? Where do you think it's going?
Yeah. So I've actually seen it all, right?
Yeah.
Really, seriously. And I think that's pretty, I'm what's the word I'm looking for? I think that's an amazing kind of experience for me as a practitioner to see the evolution of change. So when we started doing surgery for melanoma, and I was pretty interested in it from the very beginning, surgery was the primary modality for all stages. I mean, people were administering DTIC for unresectable disease, and which really wasn't useful for anything, as it turns out. And at the time, from a surgical perspective, it was pretty aggressive too. Most of the patients had pretty, I wouldn't say late stage disease. Most of them had pretty advanced primaries. But at the time, people really didn't understand any of the prognostic factors for primary tumors.
Right.
So they're all treated the same way. They all had 5-centimeter wide excisions. They tried to do these in-continuity lymphatic resections to include an elective lymph node dissection in the questionable thought, the appropriate nodal basin, right, for patients that had clinically N0. And those are big operations. I mean, the concept of removing negative lymph nodes didn't really make any sense, except that it was the purpose of trying to treat the disease when the nodal disease was microscopic, right?
Mm-hmm.
At least that was a kind of thoughtful maneuver, to try to improve outcomes by treating the disease when it was metastatic at the microscopic level rather than at the macroscopic level when patients would develop, big bulky nodal disease or in-transit disease. So what I will say was that the academic surgical community was very, very thoughtful, right? So the first kind of main kind of randomized trial was to really test the hypothesis, is elective node dissection improve outcome, right? And that was actually done through the World Health Organization, which MD Anderson was a member of, actually, which was way back then, because Charles Balch had a relationship with Pino Cascinelli. And Pino Cascinelli was the head of the surgery portion of the melanoma surgery portion of the World Health Organization, which is actually headquartered in Milan, of all places. Okay.
Oh, yeah.
So this first randomized trial was a wide excision versus a wide excision plus elective node dissection. And this was the first time that showed that if the patients had microscopic disease in one of the nodes or many of the nodes within the elective node dissection specimen, compared to patients who were randomized to a wide excision only and then developed clinical nodal disease as part of their follow-up, the patients who had microscopic disease did better by 20%, which is exactly what we found when we did sentinel node biopsy.
Yeah.
So it was a really thoughtful but the trial wasn't necessarily all that thoughtful, and except that, so it was a simple trial, which is good, which Sapna, is the best way to do a
Yeah.
randomized trial, right?
Right.
Just look at one perturbation, right? Right? Right.
Yeah.
Okay.
Yeah.
So we'll get to that shortly. So that data was really interesting, and then Don Morton had this technical paper published about the technical aspects of sentinel node biopsy, and then we republished our paper from our experience with sentinel node. So that original study kind of fostered in the concept of maybe we shouldn't be doing elective node dissections. Maybe we should just try to find the right node and just remove that. So that was the concept for the sentinel node biopsy, which was proven to be very accurate. And then we published our paper with experience with sentinel node biopsy after Don Morton published the technical portion of it that showed that a positive sentinel node was the most important factor for overall prognosis. So it had a very important prognostic implication, both as a negative sentinel node, the patient's doing great, and the positive sentinel node's doing poorly. And the multivariate analysis showed that in addition to thickness, ulceration, and sentinel node positivity was the most influential or impactful independent factor of outcome. So that's what kind of laid the foundation for the kind of the interest in embracing the sentinel lymph node concept. And the smartest thing that we did was we published it in JCO. Because that was a journal that everybody read, right?
Not just surgeons.
Not just surgeons, right? The medical oncology community would read JCO, obviously.
Yeah.
And to me, that was the smartest thing that we did, because I really think it fosters really good collaboration between the medical oncologist and the surgeons. And to me, that's what's been the most gratifying experience in my surgical career, is the collaboration with our medical oncology colleagues and our pathology colleagues, and in some situations our radiation therapy colleagues. So the whole kind of multidisciplinary kind of approach really, I think, started off because of sentinel node biopsy, to be honest with you.
Yeah, to me, Merrick, that's really interesting, because in clinical practice, for people who've practiced alongside you, that really is how you practice. You come into the medical oncology workroom and you will, you'll call up the medical oncologist and say, hey, I'm seeing this patient that we share. You really do think of it as this sort of team approach. And now that we've in many ways sort of swapped the order in which we do things, that becomes hugely critical, right? To make sure that you have a relationship with the other people on your team.
Yeah. So then, at the time when we did sentinel node biopsies and they were positive, we always did completion dissections.
Right.
But people challenged that. They said, well, why are we doing all this surgery, right? It's really just a staging procedure, right?
Most people come out negative from that. And
but the MSLT1 trial, though, showed that there was actually a survival benefit by removing just the sentinel node, right? And about 70 to 80% of the time when we did the full dissection, it was the only node that was positive.
Right.
So we weren't removing additional positive nodes very often, right? So that led to the MSLT2 trial that showed that completion dissection had no impact on melanoma-specific survival, but it did have an impact on regional disease control, right? But that we could probably accomplish if they developed regional disease at the time, in their postoperative setting. And at that time, there was no approved adjuvant therapy beyond interferon, right? And people were not really using interferon very much anyways, to be honest.
That's right. And two things I think I'd love to point out is that MSLT2 data matured around the same time that our adjuvant checkpoint inhibitor data was maturing. Adjuvant IPI and adjuvant PD-1 then became this whole, well, those trials required completion, but we don't do it anymore. The other thing I think, Merrick, that gets missed, and tell me how strongly you believe or how much we can sort of waive this. With MSLT2, since we're not doing completion dissections, positive sentinel nodal basins should then be imaged with an ultrasound in addition to whatever cross-sectional modality, right? And I find that ultrasound imaging gets missed by medical oncologists. They think, oh, we're doing the cross-sectional. Look at this one smiling over here. Do you? So do you think that ultrasound of that nodal basin is important to give added information, or the cross-sectional is enough?
So I will tell you that the cross-sectional information is almost worthless. Not completely, because if it's obvious, it's obvious, right?
Yeah, if it's obvious, yeah.
But ultrasound, there's very well-defined ultrasound criteria that can identify lymph nodes that are abnormal.
Yeah.
And it's a much more investigative modality, because it has other things you can use in real time that you can't do under CT. Because CT is a static exam, right?
Yeah.
Right. So ultrasound clearly is better than cross-sectional, images.
And I felt like that was part of MSLT2 surveillance, but medical oncologists have missed that was part of it.
That's so good that you brought that up, because it's an incredibly important point. And now it's pretty much standard of care.
Right.
That every time we see patients in surveillance, that nodal basin gets imaged with ultrasound, for sure.
That's right.
So can we move into neoadjuvant for a minute?
Of course, yeah.
So you're right. So the checkpoint inhibitors were approved, whether that was IPI, and then it moved into Nivo because of the 238 trial, right? And then in parallel, there was the targeted therapies, right? The targeted therapies were approved as well, and these trials are pretty much in parallel, right?
Yeah.
So the neoadjuvant space isn't like a new space related to just because of checkpoint blocking agents.
No.
We did do some neoadjuvant trials with either platinum-based regimens or with biochemotherapy.
Mm-hmm.
There was even some single-agent neoadjuvant trials with IPI and even with interferon. I mean, there were some. Kirkwood did a couple small neoadjuvant trials with interferon and then with IPI after IPI got approved, right? But it wasn't until, so I'm going to take credit for this, and very few people know this story, okay? So do you know where the Erie Crown Theater is in McCormick Place in Chicago?
Yeah, the east side.
Okay, the east side, right. And you remember there are all these round tables outside of the Erie Crown Theater where people would sit, and there were some food concessions there, and the concessions have kind of changed over the years. But other than that, the decor is the same. Yeah. There are these ugly round tables that sit out there and people congregate. So do you remember Jed Wolchek's presentation about...
Well, I know James remembers it.
About combination IPI-Nivo, standard IPI-Nivo, where we showed all those deep responses, like 80% deep responses, right? Mm-hmm. There was like 1 million people in that room, right? right? And I'm sitting there, I'm thinking, oh my God, this is what we need to use in the neoadjuvant setting.
Wow, fantastic.
This is from my perspective as a surgeon, I'm thinking, this is the holy grail for neoadjuvant therapy, right?
Yeah.
So the second that presentation is over, I walk out into one of those round tables and I sit down and I write this incredibly long email to Allison Hunt. Do you know who Allison Hunt is?
BMS. She was at BMS at the time. Yeah.
Right. So I write this incredibly long email to Allison. At the time, I knew that she was like the medical liaison for people who were doing investigator-initiated trials, right?
She gave me my first $1 million to do a study.
There you go. How about that? What a small world, right?
Yeah.
So I send this incredibly long email that, from a surgical perspective, I'm thinking, she's going to think I'm pretty smart, right? But so I don't hear a word. Right? Nothing. And then like 4 months later, out of the clear blue, I get this email from her saying that we want to send our science group down to talk to you guys about a clinical trial.
Wow.
Right. So this was at the time where Rhoda was but she'd maybe been there a couple years.
Sure.
And Jen had come a couple years before. So Jen Wargo. And so they came down for this meeting. And that was our first neoadjuvant
Wow.
trial, was the randomized trial of single agent nivolumab versus combination. Yeah, that was the very first trial.
Oh, that's great. That's great.
But the interesting thing, well, not interesting, because we also had a relationship with, at the time, that was GSK, because GSK had the rights for
Dabrafenib, trametinib.
right? So in parallel, we did a neoadjuvant trial with those agents for the patients that were BRAF mutated, obviously.
Yeah.
And I don't remember for sure. I'd have to go back and look at it. I don't remember if it was mandated that that the immunotherapy trials that they couldn't be BRAF mutated. I
don't remember.
I don't remember, but it would be instructive to know. It wasn't a very big trial.
Yeah.
But it would be instructive to know, because I'd like to know if there are any BRAF mutated patients in that group, because in retrospect, it looks like those patients respond the best to immunotherapy.
Right.
The ones that are BRAF mutated.
Positive. Yeah.
So anyways, that trial showed that there were some progressors on single agent, but no progressors on combination. And I think the complete pathologic response rate was about 45%, I think, something. So anyways, those were, from my perspective, the most influential trials that we did from a kind of collaboration perspective, where the surgeons and the medical oncologists were just meshed, right? And then that brings in the whole discipline of how to examine the nodes, right? So with pathology, right? So with
Pathology, I'm curious to hear from James when this was all happening, because James is first and senior author on all that Checkmate 067 business. So this is happening, and you're seeing it for metastatic disease. There are these ideas brewing for using it in the neoadjuvant. Was that something you think your surgeons were ready to hear? They were ready to hear, oh, maybe I don't wield the scalpel first. Maybe James has this therapy that could go for. Do you think that they were ready for that, or they needed to see the pilot work from MD Anderson and some of the other pilot studies that were done?
Yeah, it's a good question. I mean, I think we probably did need to see the pilot work, is one thing. And we'd ended up using neoadjuvant targeted therapy in a few situations, just in clinical practice, actually with quite disappointing results from a surgical perspective in terms of what happened to the patients down the line. So that's one comment. But I think even in clinical practice, prior to there being that much data available, we were treating a few patients in this kind of situation for one reason or another, and finding A, they did extremely well, and B, it didn't feel like you needed to give them that much treatment. And then this is off the back of medical oncologists giving systemic treatment for metastatic disease for very long periods of time. And honestly, we're still slightly wedded to that, I think, in medical oncology. And, it's always good to hear Mike Atkins on this subject, I think, when he talks about immunotherapy, and he will say loud and clear up front, one of the whole points of giving immunotherapy is that you shouldn't need to give too much treatment, which maybe that's quite a nice segue kind of back into pathological response and trying to work out who the patients are who really just need, let's say, 2 months of treatment, and then you can stop. But go on.
So I think it's worth making a few comments about neoadjuvant targeted therapy from the perspective that I think that we learned that even though you could achieve a complete pathologic response in a significant proportion of patients, that those patients didn't fare as well long term as the patients who had a complete pathologic response from immunotherapy, right? And even the patients who had a partial response to immunotherapy, in the long run, ultimately are doing better than the patients who developed a complete pathologic response with targeted therapy.
Yeah.
So, but to me, it was a lesson learned in the sense that, well, we tried, right? But maybe this isn't the right neoadjuvant approach, right? But we shouldn't dismiss the possibility of using it in some situations as a marker for a therapy that a patient can respond to. Like, for example, if someone fails, let's say they have a positive sentinel node, and let's say they go on single agent whatever, either Nivo or Pembro or whatever. And then they develop a nodal recurrence, right? So the first maneuver is clearly to try Ipi-Nivo, right? Or just operate on the patients.
Take it out, sure.
But then what do you do in the adjuvant setting, right?
Yeah.
So what do you do in the adjuvant
You don't
setting?
know.
Without knowing that they're going to respond to targeted therapy if they're BRAF mutated, right? So to me, that would be a situation in which I would use neoadjuvant targeted therapy to see if they were responders. And then do the surgery and then use it in the adjuvant setting, right? Because in reality, to me, it looks like targeted therapy is a better adjuvant therapy than it is a neoadjuvant therapy. And I think it's because they're more likely to have very little clonal differentiation, where targeted therapies won't be effective. I think you could get rid of all the disease in the adjuvant setting with targeted therapy.
Yes.
But I also think on the flip side, I think targeted therapy is a better adjuvant therapy than immunotherapy is, because I don't really understand the mechanism
of microscopic immune activation.
I don't understand that concept, right? So I think immunotherapy is a better neoadjuvant therapy, which we obviously learned, right, very nicely from, SW 1801, right? I mean, which to me, I don't want to compliment you more than I already have, Sapna, but that to me, in all my kind of career of 37 years, is the most influential trial that we've seen in melanoma. I just, for a variety of reasons. One, because it was the simplest trial you could do in this setting, right? And the easiest to understand, because there wasn't any confounding factors that influenced the outcome. It's only sequence, sequence. That's it. That's it.
And, we obviously now in hindsight, we now are interested in thinking about, can we do less surgery? Can we do less adjuvant therapy? And that all comes, those are iterations that come. But I think we were just simply saying, does moving it from here, not changing the number of doses, does that influence? And it tells you macroscopic tumor activates the immune system in a way that solely microscopic tumor left behind is not able to do it. So I think it was at least a starting point. But you said something, Merrick, that I hope if people are listening, they really key into. You've already said, look, this is obviously a clinical conversation between surgery and medicine, but there's that pathologist that cannot be out of the loop here. In fact, what they and the information they give you after neoadjuvant therapy can now start to influence what you do post-surgical. So then at what point do you loop in the pathologist? How do you let the pathologist know this is not a routine sentinel evaluation or even, therapeutic removal of lymph nodes? This is actually, this sample's been exposed to neoadjuvant. What's the best way in your mind to communicate that? Because that still seems to get missed in community and academic centers.
So it's the responsibility of the surgeon that when they post the case, there needs to be a note that says that this is a neoadjuvant patient, and that pathology needs to be made aware of that.
Okay.
And it's right now at MD Anderson, it's just
standard practice.
It's just standard, it's just routine. And you always get the report that has, there's 20% viable tumor. The non-viable tumor is 60% fibrosis or hyalonized fibrosis, and the rest is, melanophages or whatever they use. And that information is important. It is important because when you're talking about response-directed therapy, that information is the center point in making those decisions.
Yeah. And at some point, I think we're due to have a pathologist on because, that stuff is also evolving. The original cutoffs from the white paper were using the best they could. Michael Tetzlaff gives this fantastic analogy, of all of the thin slicing that was required back in the Sentinel days, that is required now with neoadjuvant therapy. He says, look, it may be that we can just coarsely section these neoadjuvant exposed lymph nodes. But we're going to have to start with the thin section. If your house has been burglarized, you want the police to come and look in every room, right? You want them to come check every room. So you want me to thin slice this lymph node before I can tell you, well, the most common rooms that are burglarized are the bedroom and whatever, the study, right? Before I can tell you I can back it down, you want me to look in every room. But,
so that's a great analogy,
right?
I've never heard that before,
Yeah.
but that tells you, like, one of the many things that sentinel node biopsy contributed to the field was that concept of very careful pathologic evaluation.
Right.
And so that practice got extrapolated into looking at neoadjuvant specimens.
That's right.
So there's been a lot of contributions related to the use of sentinel node biopsy that people don't really recognize, right?
Yeah, I think you're right. Maybe in our final few minutes, you can take us to the metastatic setting, because now, as James mentioned, we medical oncologists are giving immunotherapy mostly. And then at times we're giving a lot of it. And something happens in the evolution on our way to sort of chasing that complete response on the scan. Something happens where sometimes the response plateaus. You don't see any more shrinkage. You don't see any new disease developing. We're still giving all this immunotherapy. But is there a role then for consolidating whatever response we're seeing on the scan with maybe a resection of residual disease so that we can ask the pathology and maybe even stop treatment?
Yeah, so there's a couple approaches to those patients. So I think generally speaking, and maybe James, you can correct me, I don't know Sapna, I don't know if people are routinely only using PET scans for surveillance on treatment, or are they using just cross-sectional studies? Either of you?
Both.
Is it both?
Yeah, it's a mixture, to be honest. And it's quite messy, I would say, as well, but carry on.
Mixture is a better word. I don't mean they're using both on every patient.
Yeah, no, I get it. So Georgina Long would tell us that she thinks you can use PET scans for that. And I actually don't agree. I actually don't agree. I think what can happen is that even though something is not PET avid, doesn't mean the cells are dead.
That's right. Yeah.
I think it just changes the cell cycle for some patients.
Yeah.
That it doesn't always correlate into non-viable tumor. Right. So go ahead.
Well, I have a comment about that. So in our SWOG protocols, a PET CT for melanoma requires 2 IVs. It requires 1 IV for the FDG, for the PET portion, and it requires another IV for iodinated contrast for the CT portion. Yeah. And most hospital protocols, at least in the US, are PET CT with non-iodinated CT scans.
Yeah, that's
They're
true.
non-diagnostic. So guess what we're missing? Any real activity in the liver. You know, the liver has baseline hypermetabolism. So when your tumor gets small enough, gets under the level of threshold of that PET CT, now it's say 5 or 6 millimeters. The background FDG avidity may or may not match that of the tumor. Without contrast in the liver, the radiologist is going to be hopeless at telling you if anything is still active in the liver. So that's the other problem with PET CTs. If we're not doing them correctly, you could easily miss something in the liver if it's not done with CT, with contrast in the CT portion.
Yeah, and I find PET CT really quite difficult to interpret often, honestly, for people who are on checkpoint inhibitors and
reactive nodes and
and all the rest, actually. And so I personally, I agree with you, Merrick. I find it difficult to have a strong view that there's one particular imaging modality that's really going to help us with the decision making in this situation. And I have to say, we're still tending to do this case by case, to be perfectly honest.
Yeah. So it's pretty clear, though, that radiographic imaging definitely underestimates the incidence of complete pathologic response. For sure. So one option would be, particularly if it's in a really difficult surgical location, you could do CT guided biopsies.
Mm-hmm.
And probably do the biopsies in more than one location of the lesion, right? And so that could be helpful, I think, in patients that are not the best surgical candidates, or if it's in a difficult surgical location that could cause morbidity to do the surgery. then one option would be to do needle biopsies under CT guidance. So that's only would be one option, but I certainly feel compelled that I think surgery can have a benefit in those patients that may have kind of clones of cells that are non-responsive or not as responsive as the rest of the disease. So certainly it would be nice to do a trial related to that. Pretty hard though.
I guess I don't have a sense when we pull in our surgeons for metastatectomies after they've been on immunotherapy. I don't have a good sense. I wonder if either of you do. What percentage of that pathology comes back? No viable tumor, it's dead, versus some residual cancer cells. Glad that we got it out. Like what's our breakdown there?
But you could, there's probably data I don't know that there's a paper that addresses that issue, but it would be an easily identifiable thing, right?
Yeah.
Right. Certainly all the neoadjuvant stuff that we do Sapna when we remove residual nodes, even though there may be clinical disease still on exam and on radiographs, that what percentage of those patients that still have demonstrable disease have a complete pathologic return?
Yeah.
We probably don't have as much data for distant disease that's removed. But it would be a completely reasonable study even in the retrospective sense, to poll different groups that have done metastasectomies, and see how many of those patients had complete radiographic responses. But obviously, those patients wouldn't have surgery because you wouldn't be able to identify them, right? Unless we had put a fiducial marker in to begin with.
Yeah.
Which is what we do with all of the nodal stuff now.
Right.
That every single patient gets a fiducial marker before they start therapy.
Right. Yeah. Because it can melt so quickly. You want to know where it was. Just as a sort of point of reference. So in uveal melanoma, every now and then patients, the majority of patients get radiation to their eye. They rarely get upfront enucleation. But, in some of those patients of 80% who get radiation, a portion of them develop radiation retinopathy, pain in their eye, and they down the road get enucleated. And I've always been fascinated by the pathology report that we get at that enucleation. It's an irradiated tumor. They have no evidence of distant metastasis, and the tumor gets removed a year, 3 years later. And the pathology will tell me something about the uveal melanoma. And so my question, and this is in that same vein, is, okay, what are you trying to tell me? Are you trying to tell me there's active uveal melanoma when it should have been irradiated and completely killed with brachytherapy? Or are you just telling me this is where uveal melanoma was and this all looks necrotic and dead? They're not reading it like neoadjuvant therapy, but what are they actually trying to tell? And this has always fascinated me. Do patients whose reports say, uveal melanoma measuring 3 millimeters by 7 millimeters, is that a patient that actually I should be following at any more close of a clip because there is residual melanoma there, and we've never been able to sort that.
But that goes back to your point about having the pathologist know that a specimen was irradiated or not.
Yeah,
right?
That's right.
So to me, that's the responsibility of the surgeon.
Yeah.
Well, I'm going to enucleate this eye. I need to know if the patient's had radiation. Is this a dead tumor because it's been irradiated or it's not completely dead? But it's also important to recognize that the complete response to of an irradiated tumor is different than a complete response to immunotherapy because it means something different, right?
It most likely does mean something different.
Right. So the radiated tumor means that the local therapy was very good.
Right.
But it doesn't translate into improved outcome.
It doesn't have a systemic effect.
Right. So the meaningfulness of a complete pathologic response after neoadjuvant immunotherapy has much greater implications, I think. Don't you think? I mean,
I think so. I think you're right.
Maybe that's a good place to wrap up. That's a great message. That the context is going to be important. So I think we're almost up to 40 minutes. So Merrick,
I just wanted to make one more comment though.
Go on.
How surgery has evolved over time. So now because TIL is approved in second line setting, it's like a whole new discovery process, right?
You're right.
Right. So removing these tumors is not is not the goal of like
Yeah.
surgery for TIL. We need to understand what it means when we harvest these tumors. Like, do we have predictors if they're going to be good TIL candidates or not? So there's like a whole nother discovery that needs to happen as we
And
move
I actually
forward.
think we need that advisory board from Iovance, Obsidian, any of these TIL companies. We actually need the one that is mostly surgical oncologists with medical oncologists using these therapies, because that is the question. Is one site superior to another in terms of harvest, ex vivo expansion, size of tumor? Should we get multiple and combine them? Should we grow them separate? There's so many questions around the TIL harvest. You're right. This now, like for example, in Colorado, we're hiring essentially a TIL cert. We just need somebody who can help us with
Right.
the volume of TIL.
Right.
You're right.
Exactly. Yeah.
Yeah,
So
that's
just as a final kind of comment, I think it's important to recognize that the surgical community, particularly surgical oncologists and in academic settings, have been so responsible in doing the right studies to
yeah,
prove that we can safely de-escalate surgery in certain situations,
yeah,
and that the decision to be aggressive or not aggressive is not a simple thing, but does require kind of selectivity and collaboration with our medical oncology colleagues and our pathology colleagues. And from that perspective, to me, multidisciplinary care for melanoma is like the primo to me is the gold standard,
yeah,
because
yeah.
we have collaborated so effectively over the last 30 years. It's just been incredibly gratifying. Right.
I think that's a badge that many surgical oncologists can wear, but few can hold in like as their highest. And Merrick, you really are that surgeon. Maybe in closing, I'll just tell a story of a patient. You and I shared a Texas Tech professor. This was
Oh,
back in our
oh my God. Yeah.
Ipi and chemo days.
He's still alive.
And
He's still alive.
he was when I left,
Yeah.
and he was a really refractory case, was not terribly chemo responsive, not terribly ipilimumab responsive. This was Ipi at 10, if I'm not even mistaken. I think we played around with it. And there was some really large intra-abdominal, I'm forgetting if it was adrenal or bowel.
No, it
Liver,
was some retroperitoneal
something.
metastasis in the left lower quadrant that involved the entire left colon.
Yeah.
And I still have nightmares about doing this surgery because it easily could have gone south, right?
But importantly, you were willing to at least think about it. And then I will never forget this. You postponed a vacation. I think you were going to Hawaii or somewhere. You postponed your vacation to slot in a challenging surgical resection that ended up curing this guy.
He is unbelievable. He was so sick.
Yeah.
I mean, his performance status, I think he was
in the gutter.
He was an ECOG 3, I think.
I mean, he wouldn't have qualified for a trial. There was nothing.
Yeah, he was just miserable.
Yeah.
And he went on to teach and stuff afterwards.
That's right. That's
being
right.
a professor.
Yeah.
Well, that was nice of you to bring that up.
No, I remember that fondly. So anyway, Merrick, this was great. Thank you for taking your Labor Day holiday to chat with us.
That's fine.
This is
great. And James, thanks so much. I know this is a work day for you, but thanks. Appreciate it.
Thank you. It's been wonderful. A tour de force, I think, of surgery for melanoma, seeing what we've done, what you've done over the last 30 years, and some incredible
really what we've all done. Right? I mean, this clearly is a collaborative thing, right?
Yeah, and some incredible excitement for the future as well. So that's a great place to end. So thank you very much.
Thanks, Merrick.
Yeah, take care. All right, bye.
Bye.
Thanks.